Welcome back to the Deep Dive. Today, we are tackling something that is just about as high stakes as it gets in medical reporting. The BI-RADS 5 assessment.
We're diving into the breast imaging reporting and data system BI-RADS, and specifically looking at Category 5.
Which is where I think it's fair to say imaging certainty can sometimes collide with, well, biological surprise.
That's a great way to put it. We're zeroing in on Category 5 because diagnostically it's the top of the mountain. It is the highest level of suspicion we can assign based purely on what we see on a mammogram, an ultrasound, or an MRI.
Okay, so let's quantify that. When you say highest level of suspicion, what are we talking about in, hard numbers?
The technical definition is pretty stark. It means the likelihood of malignancy is estimated to be 95% or higher.
Wow.
Yeah. So when a radiologist assigns a BI-RADS 5, they're essentially saying, based on everything we know about how cancer looks, this is cancer until a pathologist proves it's not.
So our mission today is to explore that other 5%, that gap. We're going to look at the really surprising variety of benign things, these great biological mimickers, that can look exactly like an aggressive cancer on an image.
Right. This isn't just a list of rare conditions. It's about understanding why these exceptions happen and what they teach us.
Okay, so before we meet the imposters, let's get a really clear picture of the real thing. What does a true textbook BI-RADS 5 malignancy actually look like?
Well, across all the imaging types, you're looking for signs of disorganized, aggressive growth. Let's start with mammography. The absolute classic sign is an irregular mass that has what we call a spiculated margin.
Spiculated margin. Let's break that down. For someone trying to picture this, are we talking about sharp, spiky edges, like little legs reaching out from the center?
Precisely. That's a perfect visual. Those spicules, those little projections, they show that the lesion isn't just pushing tissue away, it's actively infiltrating it.
It's invading?
It's invading. That's the hallmark. We also look for things like architectural distortion, where the tissue gets all pulled and twisted, and very specific types of microcalcifications, fine, linear, branching ones.
Okay, so moving on to ultrasound. What are the red flags there? Is it the same kind of thing?
Similar principles, different visual. On ultrasound, we're looking at the shape, of course, but also its orientation. A benign lesion usually lies flat, sort of parallel to the skin, but a suspicious lesion is often non-parallel. We have a saying, taller than it is wide.
Ah, okay. That's a big warning sign.
It is. It'll also look dark, what we call hypoechoic, have those same angular or spiculated margins. And you might see things like an echogenic halo, a bright ring around it, or posterior shadowing.
Which means it's so dense that the sound waves can't get through it.
Exactly. It's disrupting the sound waves.
And then there's MRI, which adds that element of function. It shows how the mass is feeding itself, right?
Correct. MRI is fascinating. It shows us the tumor's blood supply. For a BI-RADS 5, we're looking for an irregular enhancing mass. But the real key is what we call the kinetic curve, how it behaves over time with contrast.
So how does it behave?
Aggressive cancers build these leaky, disorganized blood vessels to feed themselves. So they soak up the IV contrast dye really, really fast, and then just as fast, they dump it.
So a quick wash in and a quick wash out?
Exactly. We call that a type 3 or a washout kinetic curve. And it is highly, highly suggestive of malignancy. That pattern plus the irregular shape can push a lesion straight to a Category 5.
Okay. So now let's talk about the stakes here.
Yeah.
Because you said 95% plus, but I've seen the data. It's not always that high in the real world, is it?
No, you're right. And this is a critical point. When you look at the published data, the actual positive predictive value, or PPV, for BI-RADS 5 ranges pretty widely, from about 78% all the way up to 97.5%.
That's a huge range. So in some places, almost 1 in 4 of these near certain cancers are actually benign. Why the big difference?
It's a mix of things. Academic centers with subspecialists might hit that higher number, but it can vary based on the specific population, the equipment, interpretation. But the bottom line is, even on the high end, there's always a chance it's not cancer.
And because of that chance, what is the mandatory next step for any BI-RADS 5 lesion?
No ambiguity here. Zero. Every single BI-RADS 5 lesion must undergo a biopsy, a percutaneous core biopsy. You just can't watch it or wait.
And this brings us to, I think, the most important concept we're going to talk about today, the idea of discordance. What happens when the image is screaming 95% cancer, but the little piece of tissue that comes back from the lab says benign?
This is the critical moment. If you have an image that is undeniably BI-RADS 5 spiculated, washout kinetics, the works and the pathology comes back benign, we call that discordant. They don't match. The story doesn't make sense.
So who wins that fight? The pathologist with the microscope or the radiologist with a big picture from the scan?
The imaging wins, or rather the suspicion from the imaging wins. When you have discordance, you cannot trust that benign biopsy result. You have to assume the needle just missed the cancerous part.
Ah,
So that lack of correlation means you have to go back immediately. You either need a repeat biopsy or, more commonly, a surgical excision to remove the whole thing and make absolutely sure you didn't miss a cancer. This is just fundamental to safe breast care.
that really sets the stakes. Okay, so let's get into this gallery of benign lesions that are so convincing they can force a patient down that path. Let's start with inflammation and infection.
These are great examples because they show why a benign thing can look so malignant. Cancer looks scary because it causes inflammation and grows new blood vessels, while a really intense non-cancerous inflammation can look identical.
Let's start with a really unexpected one, an atypical infection, something like Mycobacterium avium intracellular.
Yes, a classic mammogram. A patient presents with a lump. On the mammogram, you see an irregular mass. You see swollen lymph nodes in the armpit. On MRI, you see an irregular enhancing mass with that classic washout. Everything is pointing to invasive cancer.
But the biopsy tells a completely different story.
Completely different. The pathologist doesn't see cancer cells. They see intense granulomatous inflammation. And when they culture it, they find the mycobacterium. So the entire management flips. It's not surgery and chemo. It's combination antibiotics.
Wow. What about something like granulomatous mastitis?
Another key one, it's rare. It tends to affect younger women, usually within a few years of having a baby.
Yeah.
And clinically, it can look just like inflammatory breast cancer. You get redness, swelling, firm masses.
And on the imaging, what pushes it to a BI-RADS 5?
On MRI, you see these large irregular masses, often with what's called rim enhancement, a bright ring around a dark center. And that intense enhancement pattern is just so suspicious. Histologically, it's all just inflammation centered around the milk globules.
This feels like a good place to bring in the most powerful diagnostic tool of all, the patient's history. Let's talk about lupus mastitis.
This is the perfect example. If a patient walks in and in their chart you see a history of systemic lupus erythematosus, or SLE, your whole perspective has to shift because the clinical presentation can be terrifying.
How so?
Redness, skin hardening, and that classic peau d'orange appearance where the skin looks like an orange peel. It looks exactly like the most aggressive form of inflammatory breast cancer.
But knowing about the lupus changes everything because you realize the aggression is coming from the body's own immune system, not from a tumor.
100%. And the management is completely different. It's medical antimalarials, corticosteroids. You actually want to avoid surgery because the trauma from an operation can cause a massive lupus flare-up. It's a systemic disease creating a very local, very scary-looking problem.
Okay, let's switch gears to our second group of mimickers. These are lesions that come from injury or unique cell types or just the architecture of the breast going wrong. Let's start with a common one, fat necrosis.
Right. Fat necrosis is basically just scar tissue that forms after fat cells die, which triggers an inflammatory response. And again, the key here is history. You're almost always looking for a history of trauma, a previous surgery, or radiation to that area.
So some kind of physical damage in the past creates this malignant look today.
Yes. The process of the fat breaking down and scarring and calcifying, it can create an irregular spiculated mass that looks for all the world like an invasive cancer on a mammogram or ultrasound. You have to biopsy it to be sure.
Okay, so if that's from an external injury, what about something like a complex sclerosing lesion or a radial scar? Is that more like an internal architectural problem?
That's a great way to think about it, yes. These are benign growths, where the normal structure just sort of collapses in on itself and gets distorted. On a mammogram, they are famous for causing architectural distortion, this star-like pulling of the tissue. On MRI, they can look like a classic spiculated enhancing cancer.
And this is where it gets really tricky, right? Because even though the radial scar itself is benign, you can't just leave it alone.
You can't, and that's the vital point. Unlike fat necrosis, a radial scar is a risk marker. It's associated with a coexisting cancer, either invasive or DCIS, in about 4 to 9% of cases.
So even if the biopsy needle only hits the benign radial scar, you still have to recommend surgery to take the whole thing out, just in case there's a cancer hiding right next to it.
That's exactly right. Because of that hidden risk, surgical excision is usually the recommendation. You have to see the whole lesion to be safe.
Let's touch on two rare tumors that cause these diagnostic headaches. First, fibromatosis or a desmoid tumor.
This is a really interesting one. It's a benign soft tissue tumor, but it's locally very aggressive. The key diagnostic clue is often its location. It's an irregular mass, but it frequently involves not just the breast, but the pectoralis muscle underneath it.
And the treatment has to match that aggressive local growth, even if it won't spread around the body.
Absolutely. It requires a wide surgical excision. The risk of it coming back right in that same spot, local recurrence, is high, 20 to 30%. So you have to be aggressive to get it all out.
The other one, a granular cell tumor.
Another great chameleon. It's rare. It comes from Schwann cells, which support our nerves. But its reputation comes from the fact that it can perfectly, and I mean perfectly, mimic a primary breast cancer. Irregular, dark on ultrasound, indistinct margins. We treat it with a wide local excision because, while almost never malignant, it is locally infiltrative.
Let's finish by circling back to the power of clinical history. You mentioned lupus, but what about something like diabetic mastopathy?
Yes, or lymphocytic mastopathy. This is such a great example of how knowing the patient's story can potentially change the pathway. It's very strongly correlated with a history of long-standing insulin-dependent diabetes, usually type 1.
And what do you see on the imaging that looks so bad?
You're seeing classic BI-RADS 5 features. A spiculated mass, maybe dense asymmetry, deep posterior shadowing on ultrasound. It screams cancer.
But the radiologist who knows this patient has had type 1 diabetes for 20 years, they have an advantage.
I have a huge advantage because in this specific case, we know that chronic autoimmune response tied to diabetes can create these inflammatory changes. And knowing that history might allow the radiologist to say, okay, this looks like a 5, but given the history, I'm going to call it a BI-RADS 4.
Which avoids that automatic discordance problem if the biopsy comes back benign.
Exactly. It helps manage the downstream pathway. The ultimate treatment is conservative, of course. It's self-limiting, no cancer risk, but that little bit of clinical knowledge can make a world of difference.
It's clear from all this that breast diagnosis is so much more than just looking at a picture. What's the biggest takeaway here for our listeners?
I think the central point is that imaging is powerful, but it's not perfect. We've seen so many examples: infections, inflammatory conditions, scar tissue, weird benign tumors that can all look exactly like a BI-RADS cancer.
And if you remember nothing else from this deep dive, it has to be about what to do when a benign result comes back for one of these scary-looking images.
Absolutely. The single most important principle for patient safety is this: a benign core biopsy for a BI-RADS 5 lesion must be questioned. You have to confirm that it's concordant, that it makes sense with the imaging. If it doesn't, if that radiologist still thinks the image looks worse than the pathology report, you must go back for more tissue. The imaging suspicion wins until proven otherwise.
It's just incredible. The whole process is about reconciling the crystal clarity of that scary BI-RADS 5 image with the potential ambiguity of a patient's story or the microscopic view. And it leaves me with this thought for you to consider. In a world where AI is getting better and better at reading images, how vital is that human element, that non-imaging data? A simple question about a past injury or a history of lupus or diabetes that could potentially override a perfect AI-confirmed Category 5 profile, and in doing so, save a patient from a surgery they don't actually need. It just shows you can't separate the pixels from the patient.